Hi, I'm Tyson Franklin, and welcome to this week's episode of the Podiatry Legends Podcast. With me today is James Ferrie, and he is a sports and musculoskeletal podiatrist, and he owns My Sports Podiatry in Docklands, Victoria. And today we are going to be talking about point of care ultrasound. So, James, welcome to the Podiatry Legends Podcast. I should have had you on here about 4 years ago.
Thanks, Tyson. Thanks for having me on. Yeah, I'm keen to chat about ultrasound. As we had a little bit of a chat, but it's certainly been something I've used. Ultrasound is probably something I've used for the last 10 years in practice.
Yeah, well, it's funny, just to point out that comment I made about the 4 years is it's one of those things when you're going through old messages, and there was a message from James back in 2020, and I was just flicking through something and I saw this message there and I went, Tyson, you weak bastard, you didn't reply. So if anybody has ever sent me a message over the years and I have not replied, I have not done it on purpose. And when I eventually come across it, I will reply. So if you're waiting on a response from me and I haven't replied.
It just could be 4 years.
You might have to wait 4 or 5 years. But it was good. I sent a message out to you. You didn't say I was a terrible person and you agreed to come on the podcast. So before we get into the ultrasound, I'm always curious, what got you into podiatry? Why?
Yeah, it's interesting. I guess as podiatrists, we get asked that question multiple times a day. Why did you choose podiatry? So you have to have some sort of reasonable answer for it. And I don't think my answer is that. But basically, I was looking at, I liked the science-based subjects when I was at school. I was better at those than I was in terms of the arty subjects and the English and the literature and all of that area. But I didn't really want to work in like the hard sciences. I like working with people and I like problem solving. So I saw healthcare as being a pretty good mix there. And I did actually spend a bit of time looking at, chiro, osteo, physio. And I spent some time going in and sitting in with a physio, sitting with a chiropractor and osteo. And at the end of the day, I think I looked at all of them and there was a few things like chiro there's some fantastic, I work with some really good chiros, but for me, it was a little bit repetitive. Osteo was a bit too hands-on. I didn't really want to get as hands-on with patients. And physio, I thought there's a lot of exercise prescription that people aren't going to do. Yeah. There's a cohort of patients that follow prescription. And I liked with podiatry that there were specific sort of interventions and things that you could put in place that were not as dependent with the patient. So if your success of your career in healthcare, I think our success is getting patients better. And if that is determined by how much work the patient puts in, they all have to put in some work, but I thought that would be a little bit of a difficult career path to see someone 2 weeks later. How's your shoulder pain? Oh, it's not much better. They've done no exercises. They've done nothing. That'd be, I think, not that wasn't quite for me. So podiatry was something, and I also liked I liked the mechanical aspect of it. So that ability to mechanically look at structures. I always liked biomechanics. And I guess that's that ability to take someone's ingrown toenail out or to do something that would actually provide quite immediate relief for people as well.
So how did you come across podiatry though?
I was lucky enough to have a good podiatrist when I was a kid and I had foot pain. So, Bernard Comerford in Essendon was a podiatrist my parents took me to when I had some basically sore feet at the age of, it would have been like maybe grade 4 or something like that.
Yep.
And back in the day, got me walking on the treadmill, prescribed a pair of orthotics and foot pain was gone. And then I grew out of those orthotics and I didn't necessarily have foot pain after that. And so it was always in the back of my mind. And I think maybe when I was in year 12, I wasn't really thinking podiatry, but I had an appointment. I had to go to the podiatrist back to Bernard for something. And I actually thought, I might have a look at this. This looks interesting. So I rejigged my preferences and here I am. All those years later. It's a rewarding career. I'm never bored working in podiatry. There's always so many different avenues and different areas that you can focus on and find an area of interest.
Yeah, I always find it funny when people are saying, I thought I wanted to be a physio, and then they come across podiatry. And I always look at physiotherapy, and the thought of actually having to rub somebody's butt is just not appealing. Like I'm sure there's some good butts, but I'm sure there's a lot that aren't. And I really don't want to be down there digging my elbow into it, and it just doesn't thrill me.
Yeah. I've got one. So this is many years ago. It would have been when I was first started practicing, and I had probably once a month where I was working. We had a contract with like an aged care sort of hospital. It was rural. It was out in Gippsland. And I remember going there and some nurse was going, "Oh, I don't know how you do feet. I just don't know how you do feet." And then it would have been maybe a few hours later. She comes running down the corridor with no top on. She's taken her top off and she's running down the corridor. And anyway, when I caught up with her
Was
a
this
little
the
bit,
patient or the nurse?
this is the nurse.
The nurse is
And
running down the corridor, no top on.
yeah,
Okay, yeah.
she was helping a patient with a hoist onto the toilet,
Oh,
and
okay.
the timing was a bit off. So after that, she did apologize and says that she can understand how this would maybe be less desirable than looking at feet all day. And she actually probably wouldn't mind after today to look at feet.
I know. I remember saying there was this list once of top 10 worst professions. This is years ago in the paper. One job was sniffing armpits. And podiatry was in this list as well at the time. And I'm thinking, I'd look at feet every day of the week, then sniff somebody's armpit. I don't know what podiatry is even doing in that list. It was ridiculous.
Yeah.
But anyway, you're doing it now. You liked it. I liked it. And so once you graduated, where did you head off to?
So I worked up in Gippsland with Aaron Bryce for the foot and ankle clinic. So I was managing the sale practice up there. And that was a fantastic experience because I think back then, unlike today, there was a lot of podiatry graduates. So the course size that I would have gone through with is probably 3 times the size that La Trobe are putting out now. So there was a lot of podiatrists. There was also a lot of low-end work. There was a lot of like jump into a GP practice, bulk bill EPCs with no real, basically not letting your skills develop at all. You're pretty much just doing general care type treatment. So you're not using any of your biomechanics skills. You're not using any of your MSK skills. You're not doing any procedural stuff. It's just very much that sort of routine bulk billing type stuff. That was very unappealing to me. Whereas basically up there, we had it was a standalone clinic. We had great services. We had shockwave. We had laser. We had really the sort of full breadth of scope of practice that you could use in podiatry. And then the other thing is, I think it just comes down to people in the country are very appreciative of good services.
Yeah.
And it is really supportive as well. So it's supportive also by the local healthcare and medical team as well. They tend to refer. And you do see a lot more sort of complexity because if you're in a big city like Melbourne, Sydney, Brisbane, Perth, something like that, there are, for the same patient cohort, you've got orthopedic surgeons competing for that, sports med doctors competing for that, physios, osteos, chiros. Whereas I guess more rurally, because the services are generally pretty full to start with, the chiropractor is not going to spend heaps of time trying to deal with someone's plantar fasciitis because they've got a waiting room and they've got a list of people that are trying to get in to see them. So they'll just say, listen, that's not my sort of thing. Go and see such and such.
Yeah.
Whereas I guess in that sort of more competitive environment, you find that you don't see that sort of complexity. So, you're seeing acute fractures, you're seeing wounds, you're seeing Charcots, you're seeing the whole breadth of what podiatry has. And I think it's good experiences when I was young to literally see that and to manage all of those different areas. And then in the end, I knew what I was good at and I knew what I was interested in. So when I went out on my own, I was able to say, listen, this is what I do. I've done all of that stuff, but that's not my area of interest. This is my area of interest. And I was able to create a business around what I like.
Yeah. And I think that's really important. I've said it on the podcast numerous times, and I get podiatrists, and I was talking to someone yesterday who they'll contact me just to get like some career advice, some ideas and thoughts on where they should be headed. And I say to them, just find what it is you like in podiatry and just set a goal that you want to do more of that than anything else. And then just keep building on it as the years go on. That's if you're working with somebody else. And then when you set up your own clinic, don't do what everybody else is doing. Just focus on what it is that you like doing, and you will build the business around that. And you said before we pressed record that you just focus in that sports area, just private practice for people that are actually going to pay you. Yeah, not worrying about any government work. And it is slower at the beginning.
Yeah.
But eventually it pays off.
It's true because it's hard when you first start as you said, it's hard to turn money away when your books aren't full and to say, sorry, I don't do that sort of work. But the problem is that you end up the other way around where if you take that if you want to focus on really being good at MSK and you want to make a clinic around MSK, if you fill your books up with general care, that's partly what you get known for. But also your books end up full. So it's hard to get those patients, those new patients in, particularly with I do a lot of clinical education around shockwave and ultrasound and with injection therapy as well. And we often get people that come and they already own their own practice, but they're full of work that they don't want to do. And they
Oh
come into
yeah.
this course, I'm doing a lot of this, but I want to branch into something else because I've got bored of this. And the thing is that when you have a conversation with them, a lot of them never liked that work at the start, but
Mm.
it just paid the bills. And then now they've got a business that they don't necessarily want. They want to branch out and do something else, try and reinvent things. And sometimes it's a bit easier at the start to just have that sort of vision of what I want to do. And for me, it was MSK. So it's not so much like for me, my ideal client is like your weekend warrior.
Oh
They're
yeah.
compliant. Dealing with the athletes, I don't mind dealing with athletes, but they're harder work. They're harder
Bit
maintenance
of a
and
pain in
stuff
the
like
ass
that.
sometimes.
Yeah, the sort of the weekend warrior with a Achilles tendinopathy, those patients are great. I like them. They're compliant. They've got realistic expectations of what they want to achieve. They work really well. So they're my bread and butter.
Yeah, when we're talking about the type of patients that you want, and I always say to people, when you set up your clinic, for every person you're saying yes to, you're saying no to somebody else.
Yeah.
So if there's a type of work that you don't really like doing, it's okay to say no. Send them to the other person down the road who might actually prefer doing that. And that keeps your time freed up to eventually see more of the patients that you actually want to see.
It's very true. And I guess also like going out on your own into business as well. At the start, when you have lower resources, I didn't have and again, it wasn't a I didn't have the resources to chase accounts from
Mm,
things like third parties. So that was the other thing that I said no to was third party work. So I don't accept TAC, work cover, NDIS. I think that I have to invoice or deal with a third party. And the other thing there is just a lot of the time, like when I was dealing with TAC and work cover patients, which I did with my first job, there's often a lot of anger that some of those patients have at the whole system as a whole, because usually after they've been in that for 12, 18 months trying to get a resolution of something, dealing with caseworkers and so many avenues, they often come in bitter and twisted by the time they get to you. And it almost sours that therapeutic relationship to start with. So it's actually sometimes a nice thing to say, listen, you're welcome to come and see me, but I don't deal with TAC, work cover. I don't deal with those organizations. And for some of those patients, it's really refreshing. Like, okay, I've actually been dealing with this for a long time. I just want to get this resolved. I want to get back to work. I've got a goal in mind, and they're a bit sick of that process by that stage.
we had the same thing. We had our clinic. We would take an EPC patient referral, but they just had to pay us and we would just give them the receipt and you sorted all that from your end because we didn't want to get bogged down in the paperwork, in chasing up things. Were people, had they already been given the go ahead to start treatment? And then if they weren't, they would then take it out on us. And we go, we didn't deserve that. So we were the same thing, just focused on the private patients that were paying.
It does. It saves you, and I think also they have become more difficult. A lot of those third parties have become more and more difficult to deal with. Like you don't get. They patients used to get a caseworker. There used to be a direct email address, a direct phone number. That all changed. So it's now just send an email to claims at TAC or work cover, and we'll respond to you in 7 days or something. And then there's a lot more. They're constantly sending you. They were by the end of it, they were constantly sending sort of letters saying, listen, you have to fill this report out for this patient and you got to outcome measures and all this sort of stuff. And it's like, and all of that's, again, most of that sort of unpaid admin time that effectively fills up. And there's already so much in healthcare. There's already so much administrative burden that's there. That's just a whole sort of another sort of level on that.
I thought now would be a perfect time just to dive in and let everybody know that I'm now offering hourly coaching sessions. I've had a number of podiatrists reach out to me recently who didn't want to be part of a larger coaching organization and didn't want to do ongoing monthly coaching. And this has become really, really popular. I didn't realize how many podiatrists would be interested in this. So if there's an aspect of your business, whether it could be a marketing question, it might be something to do with a team member, you might want to know how to attract the right podiatry team member to your business. Doesn't matter what it is. If you want to talk to me, you can block out an hourly session. And yes, it is a paid hourly session. If you go to my website, tysonfranklin.com, all the information is there. And from there, you can click on the link and you can book in an hourly session with me. And I've been in the podiatry industry for well over 35 years now. I have owned multiple businesses, and there's not too much I have not seen. And I continue to go to business conferences myself so that I can adapt that knowledge to help podiatrists better. So go to my website, tysonfranklin.com. If you want to do an hourly session with me and not commit to any long-term ongoing coaching sessions, please get in touch with me. Okay, let's get back to this interview. So let's move on to, how did you get into this whole ultrasound side of things?
So ultrasound was, when I was working up in Sale, one of the difficulties we had was getting an ultrasound. So sonographers were really difficult for the hospital to retain up there. So the turnaround to get just an MSK ultrasound done was about 7 weeks.
Oh,
so it would fluctuate between about 4 weeks through to about 7 weeks to get an ultrasound. And then the alternative was they would have to travel to a neighboring town, which is probably about an hour and 45-minute return trip. So it was effectively half a day or a day off work to go and get an ultrasound. And then the quality of the reports were often so low quality that I'd get a report back. You send someone for plantar heel pain, come back and say, look, the plantar fascia is thickened, hypoechoic, and that's about it. So it's 2 lines. And I probably could have told you that from doing an assessment on the patient that was likely, what the report was going to come back with. So some of it was low quality. It really depends with sonography who does the ultrasound. So the sonographer, they are clinicians as well. And effectively, it depends on where their skill set lies. So if they do a lot of general sonography, they may not have an interest or a lot of experience with MSK stuff. They might only do a few foot and ankle scans every month or so. So it really depends. Where you can go to some places that have really skilled MSK sonographers who are excellent at what they do. So just like in the world of podiatry and other healthcare, sonographers specialize a little bit into their areas of interest. And then at the time as well, I was also getting into a lot of the regenerative side of things. So Margaret Taylor, who's a doctor from Adelaide, she really brought prolotherapy to Australia. And I remember as a sort of a new recently graduated podiatrist, went to one of her courses, and she was really inspirational in terms of what she was doing. And a lot of the concepts seemed a bit too good to be true. And for some of those difficult patients that I was struggling to get a result with, I ended up employing some of those techniques and was blown away by where that went. And that really got me interested in that regenerative medicine space. So I moved into doing sort of PRP and orthobiologics. And when you start to go down that path, ultrasound becomes something that you need, because you really need to be able to guide your procedure. If you're going to charge somebody to do a PRP injection into the plantar fascia, you've got to be sure that's where you're
putting it. Yeah, that'd be helpful.
So ultrasound was one of those things that I was always interested in. And when I called the GE rep, he'd never sold an ultrasound to a podiatrist, and so he had no idea. So he come up, and for the first probably 6 months or so, I self-taught myself ultrasound. I read everything I could. I scanned. It's a skill that you need to spend a lot of time scanning. There's a steep learning curve with ultrasound, because what people often ask is like, oh, well, how do you interpret the image? The problem is you've got to be able to acquire the image first and then optimize it in order to be able to interpret it. So I got my skill sets to a certain point, and then I approached a company in Melbourne. They're called Zedu Ultrasound Training Solutions, who I now basically work as a clinical instructor for. And at the time, they hadn't also done any work with podiatrists. So they teach point of care ultrasound to doctors primarily. So point of care effectively stands for ultrasound that is used at the point of patient care. So these are clinicians who are using ultrasound to make clinical decisions. It's a bit different to a radiology. So we might use the same technology and we might use some similar skills, but we tend to approach things a little bit differently. So I'm not a sonographer. So a sonographer and a radiologist still a really important place in that healthcare system. But as a clinician, ultrasound becomes like an extension of my clinical exam, where we're using ultrasound to be able to visualize some of the structures that we're looking at. So they set up basically a course, and with another pod up in Noosa, Craig Wanless, we basically did a course together with them. They get patient models in and we scan. And then from there, I work with them to develop a foot and ankle ultrasound course, which we've really tinkered with and optimized now, which is a 2-day course we run probably 3 to 4
Okay.
times a year. And it's a really intensive, and it's designed to give the clinician. So we've had orthopedic surgeons through there, we've had pod surgeons and podiatrists that have come through and done that course. And it's basically like to give you all the foundational skills. It doesn't teach you to become an advanced sonographer in 2 days, but it gives you the foundational skills to be able to start that journey. And from there, you can continue to build. And my skill set's always building and evolving
I
because,
was going
as
to
I
say
said,
that because even once they learn the basics,
the doing is really important.
You can learn the skills, but until you're applying it with the patient, what you're seeing and the symptoms that are coming through, the more you do it, I assume just the better you're going to get with it all.
Exactly right. So the difference with ultrasound is, as I said, it's relatively unhelpful when I get a report back that says the plantar fascia is mildly thickened and hypoechoic. It doesn't give you a whole lot of detail, but because I scan thousands of heels and thousands of patients, it really helps with your ability to develop clinical algorithms around what sort of what the grading of that pathology is. But for example, like if I look at someone's plantar heel, I'm not just measuring the thickness of the plantar fascia. My exam starts off you're looking at the shape, the osteology of the calc. That gives you an idea of compressive load that's on it. You look at basically the fascia, you look at the echogenicity, which is effectively the architecture of the fibers. We look at whether there's intrasubstance tearing, whether there's delamination. We look for whether there's defects in the macro chamber of the fat pad. We can dynamically assess those things. And then also looking at the tarsal tunnel as well, so we can assess the tibial nerve, the medial plantar nerve, lateral plantar nerve, the infracalcaneal nerve or Baxter's nerve, your medial calcaneal nerve. And then you can also look for things like fatty atrophy in the muscles if you've got a suspicion there's a neuropathic element to it. So all of a sudden, I'm looking at a whole lot more complexity around the heel pain diagnosis that I just can't get from my average sonography radiology clinic. So that ability, and this is something, again, that exams evolve, but once you get competent at it, that exam takes me probably 5 minutes to look at all those structures, five to
Yeah.
10 minutes to
So,
go
but when
through
you were
it.
using the sonographer, were you actually listening that you wanted all these things looked at, or
They just could, if
they
it's not
don't
on
have the time to
they
do it?
don't have the time to do it, or they don't have, and it depends on the skill set. You could ask, sometimes you'd send them for an ultrasound and you're querying like a syndesmotic injury and you're questioning whether the AI TFL's been injured, and they do a report and it's not mentioned and it's not visualized. That's just because that particular sonographer doesn't have the skill set to find that ligament. The same goes with a spring ligament. You might say query a spring ligament medial capsule injury. And because that's not necessarily part of the standard protocol, it'll come back and it'll come back clear.
Okay. So when you're doing it yourself, though, you might have 3 or 4 different ideas of what you think could be going on. So you can just go and look at those 3 or 4 things.
Exactly right. So you're approaching it different. Ultrasound comes in clinical practice wise. The patient is going to pretty much 80% of the diagnosis is in the history. The patient's almost going to tell you the diagnosis. Yeah. So if you take a thorough history, you should probably have a provisional diagnosis by that stage and several differential diagnoses. And then your clinical skills are effectively you confirming or falsifying those. Okay. So if someone says, for example, they've got, this is a case I saw during COVID. A lawyer, 40-year-old lawyer, comes hobbling in, really antalgic gait. She says, I've got plantar fasciitis. Both my parents are doctors, and they said I've got plantar fasciitis and that I need an orthotic because that's what they have, and they've also had plantar fasciitis. In the history, it was in one of Melbourne's big lockdowns that went on for on and on. So she decided she was going to take up walking, which she hadn't done. So she walked 15 kilometers the first day, and she managed to do about 6-7 kilometers the next day before she couldn't walk anymore. And I saw her a few days later. Now, her suspicion was she had plantar fasciitis, but then when she comes in and you're palpating that plantar fascia, it's not tender at the plantar fascia insertion. It's not tender on the Achilles tendon either. Then you bring your ultrasound out and you assess those structures, and the plantar fascia is pristine. It's of normal thickness, normal echogenicity, a little bit of fluid in the fat pad, but otherwise normal. The Achilles tendon is also normal. There's no enthesiopathy. There's no insertional tendinopathy. There's no retrocalc bursitis. So that automatically rules out those things.
Mm.
So what you're thinking, like plantar fascial tear, because she's basically can't put the heel on the ground. She's limping, walking into the room. There's nothing in those, looking at those structures, that basically tells you that's certainly not the cause of her pain. So then you start looking on the calcaneal body, and again, you see this subtle little sort of soft spot change in that acoustic shadowing. And then you focally tender in that point. You're like, I think you've got a stress fracture. You order an MRI, and there's a 7 centimeter stress fracture in her calc. So ultrasound gives you that ability. Sometimes that ability to rule something out is actually more powerful than to see something that looks a little bit.
I was just thinking that straight away you're using it to eliminate what everyone would probably think is the obvious problem, like even her parents as doctors, so that you can then focus, okay, well, if it's not that, what is it?
Yeah. Like I've had patients that have come in again, another patient come in from a referral from her doctor, and I knew her because we used to work together, and she said, I've got plantar fasciitis, atypical presentation. Doing an ultrasound, she has basically a deep vein thrombosis of the tibial vein. And the only reason I found that is because I scanned everything else and I couldn't see anything that would be causing her pain. So then you start looking, your scan starts to become, you're starting to extrapolate larger and larger. And then she ended up having a factor V Leiden, which was a sort of blood clotting disorder that predisposed her to that. There was another patient I saw who was actually discharged from hospital because they said that it was musculoskeletal pain. History was very atypical. So again, my job as a podiatrist at that point, she comes in with a swollen, painful leg. She'd already been to hospital and they'd said it's musculoskeletal. Here's a script for some painkillers and some anti-inflammatories, and see your GP. When I did a scan, again, I couldn't find anything wrong with her foot from a musculoskeletal point of view. Nothing that could adequately explain her symptoms. So again, just using that sort of clinical logic, I was like, the only thing that it can be is a DVT.
Yeah.
I'm not a vascular sonographer, so I said certainly can't rule that in or out. I had a look at some of the big vessels, and I didn't see a DVT there. But I said to her, listen, my advice is you need to go back to another hospital and get an actual duplex scan done. And lo and behold, they did find a DVT when they did that. And that wasn't because I saw the DVT. It's just through a process of elimination, I couldn't find any other reason that would explain the symptoms and the swelling that she had.
Okay. So it sounds like it's one of those pieces of equipment long term most good podiatry clinics will have.
Completely. To
Yeah.
be
And
honest,
I'm just pointing out to people that this is, I just want to point out to everyone that this isn't a sales pitch for whatever company you represent. This is just, to me, that just seems to be based on how you're talking about it and knowing how podiatry is progressing over the years, and a lot of the dinosaurs are leaving. And the newer podiatrists coming through, I think, are far more switched on with wanting to embrace technology and diagnostic tools. I can just see this is one of those tools that every good podiatry clinic will have on site.
I think so. The ability to think laterally, when you have the ability to actually visualize the structures that you're assessing and look at, as I said, it just becomes like an extension of your clinical exam. And it's like a sixth sense that you have in clinical practice. So for even the acute patients that come in, so you might see a footy player who comes in on Monday after a big game on Saturday, they've had a big traumatic ankle injury. That ability to scan through and to look through all of those structures, it takes the guesswork out. Like I can go through, is there a big effusion? Is the syndesmosis intact? Is the ATFL intact? CFL intact? Bifurcate ligament intact? Is there a avulsion fracture of the fibula or talus? You can look for a POMI. It gives you the ability to have such a wealth and it's not always where my clinical exam ends. I still order a lot of MRIs. So if I see a really complex thing, I'll look at that and go, all right, we got a lot of stuff going on. We got a massive effusion or like a hemarthrosis. You've got syndesmotic injury. We need an MRI. It's not like that's where my clinical exam stops. It just becomes a tool. And I still refer out for MSK ultrasound. So it's not like I've completely replaced the sonographer or the MRI or the radiologist. Is still really valuable, but it also does reduce the unnecessary sort of imaging. I can escalate things higher. If I think it's a For example, like as clinicians, sometimes we might have a patient come in and you go, I don't know if this is a syndesmotic injury. Like someone sprains their ankle, the whole thing's generally pretty sore. You're palpating around a whole bunch of things. And they're like, it's sore there. Yep, it's sore there. It's sore there. So the ability to see and to go, "Right, it's intact. We don't need to get an MRI." Whereas it is ruptured, I don't know how significant that injury is. I don't know because I can't see the whole way through the syndesmosis. I'm looking at the anterior inferior tib fib ligament. I don't know how much the intraosseous component has been involved. So it gives you the ability in that circumstance to say this is a high grade injury. We need to get that MRI so that we can then make a decision whether you can be treated conservatively or whether you need an ortho opinion.
So how many podiatrists have you trained so far to do this?
So we've probably been training podiatrists since 2016 or so. I would say we would do about maybe 20 a year. The reason being is ultrasound, it's not an easy skill. I can stand up there. So if I do a workshop and get an ultrasound and I say, look, this is ATFL, this is CFL, this is all these different structures, it's effectively useless information so it takes a lot of you actually scanning. So the way our courses work is they're low ratio. So we only have 1 to 4. So there's me and an MSK sonographer that we co-teach it,
Yeah.
and we'll only have a maximum of 8 people per course. We get patient models that come in for each prac so that the podiatrists and the clinicians aren't scanning each other. And it's very hands-on. So we'll do effectively like a 30-minute lecture on, say, lateral ankle, and then we'll have a 2-hour prac scanning. And then then we'll have maybe a break, and then we've got another short lecture, and then we'll have another 2-hour prac where we're rotating through. And because patients have 2 legs, we can set up 2 ultrasound machines and have effectively them rotating through every sort of 8 minutes so they can scan something and then we move on to the next thing. So everyone's getting a good chance to build those hand-eye coordination and skill set.
Is there much prep work they have to do beforehand before they do the courses?
Look, we send them there's a few things. It's generally set up that you don't need to do a heap of pre-reading because it is something that is, if you're looking at static images in ultrasound, it's very hard if you haven't looked at them a lot to know what exactly it is. So it's not a huge benefit in looking at heaps of images, but it is useful to understand some of the ultrasound physics because that makes a difference in terms of different artifacts. So understanding what bone looks like, what's the sort of cytoanatomy of bone versus tendon versus nerve, that's helpful. One of the things that is difficult, makes ultrasound difficult, is the angle that you hit your target structure. So some structures are more reflective. So for example, tendons are pretty reflective. If your ultrasound, what we call the angle of incination, so the angle that beam hits the target, if that's not 90 degrees, it's say 80 degrees, your ultrasound is going to bounce away from the transducer. And because the ultrasound listens for that returning echo, you get an artifact where the tendon looks black or hypoechoic. So if you don't know what the artifacts are, you can misinterpret it very easy, ultrasound. You can say, oh, that looks like it's ruptured, when in fact it's just your poor technique. You're not imaging it at 90 degrees, so it looks like something's ruptured or it looks like it's pathological when it's not.
Okay. So the hands-on experience of doing it over and over again is the only way you're going to get better at it.
Yeah. Yeah. And then once you finish the course, like it's a bit overwhelming. We cover the whole foot. The first day is a focus on plantar fascia and Achilles tendon and the sort of introduction to ultrasound guided injection. So whether we're using like an in-plane approach or an out-of-plane approach and some of the technique. We've got phantoms that practitioners can inject. So we've got some vascular phantoms, and we've also got phantoms that are like a foot and ankle with, basically it's like a foot and ankle that's got various joints and stuff that's all rubberized and silicon. So you can actually try and practice doing a joint injection. And you get an idea of how difficult that is because it's a skill in itself, because the ultrasound beam is the width of a credit card. And your needle has to stay within that credit card width the whole time, or you can't see it. So if the angle's off, or you're 2 millimeters lateral or medial to that, you see nothing. So there is it's in
skill.
Itself is a skill. Yeah.
Okay, so not too long ago, there was a little handheld
Yep.
ultrasound units. I think it was a Canadian company that
Yeah,
was
there's the
promoting them.
Clarius, a
Yeah, I
Canadian.
think that was them. Yeah.
Yep.
And I know there were a few podiatrists who bought one and then they were using it in their clinic. Is it going to be a lot harder to interpret and learn if you don't actually do a course?
Yeah, there's, as I said, there's a relatively steep learning curve. So I'd be really careful if you the handhelds are great. They're like a
Yeah.
gateway drug because people don't really know whether this is a skill that they want to incorporate into their practice. Some people have a bit more of a have got a little bit more of a I guess just from a spatial, the way their brain works in terms of spatial awareness and stuff, they take to it a little bit easier. We probably have 10 to 20% of people that just struggle from the spatial point of view because it takes a little, you've got to have a certain, the way things move and the way you basically have to drive that probe. You have to change a lot of different angles. Some people find that a little bit more difficult. So some people come to the course and they say, look, it was really great. I've learned so much about ultrasound. I've learned how to interpret it, but I just don't know if it's for me. And then you get some people that just really take to it like a duck to water and they get into practice and they just start applying those skills and build that skill set up. But it is difficult. You will find that if you don't have a systematic approach to how you do the scan, it's really difficult to replicate it. So it's almost a bit like how you drive to work, for example. If I had to ask you like how you drive to work each day,
Yeah.
if you had to think like how many meters and then I turn left at this street, then I turn right at that street, then I turn left at this one, I go through the roundabout. Oh, I couldn't tell you, but I can just do it. You can just get in the car and drive there.
Yeah.
So when
And,
you're
that,
learning
and sometimes you drive to work and you can't even remember driving.
exactly,
You
so
just get there.
ultrasound's a little bit like the same. So you want to approach things in a systematic way that you replicate each time because it means that you don't miss anything and it means that you're able to just and it's hard to learn that at the start. So if you just give a handheld to somebody and you spend enough time scanning on the bottom of the foot, most people can at some point find the plantar fascia.
Yeah.
Maybe it's not a good image of the plantar fascia, but they'll be able to find the structure itself. But what the skill set teaches you is it teaches you how to be systematic. So if I'm scanning like a lateral ankle, I approach that scan the same way each time, rather than just randomly putting the probe on and moving it around until I think I can see what looks like a ligament. There's a specific way, and it's a bit like how you drive to work. You find this, then I move my probe like this, and I find this, and then I move on to the next structure. So you approach it in a specific way, and that makes it a lot easier. So if you don't work like that, it's easy to miss something. And if you can't optimize the image, and it's like how you drive the machine, then what you've got to interpret the images of poor quality, it's often not of diagnostic. You don't have enough image clarity or resolution to make diagnostic conclusions from that. And that's where people make errors. On LinkedIn, it's interesting every now and again. Like I saw one not too long ago, and it was a physio over in the US, and obviously he's just got an ultrasound, really passionate, really like it. But he's posted a image of a calf muscle where he's diagnosed a tear and he's making a measurement and he's showing that this patient's presented with this pain but what he was looking at is a blood vessel that's passing through the muscle. So it's not a tear. So
Did you point that out or you just
oh,
send him a private message?
I just let that go. I don't really want to. I don't really want to. It's not my. It's not my place.
No, it's quite interesting you say that too, because I'm reading a book at the moment. It's got the top 20 things that leaders do wrong. And one of the things is when somebody has made a mistake is to point it out to them very quickly that they've made a glaring mistake. So it makes you look smart and makes them look dumb. Yeah. And they reckon that is really bad. And God damn, that happens a lot in social media.
It does take a little bit of time so that you're actually interpreting the right thing.
Yeah.
You've acquired the right image and you're looking at the right thing and you understand what normal muscle should look like. You understand what normal tendon should look like. And the thing is that it just takes a lot of practice to, I guess, build that library up of what normal looks like, because you can't make an inference of what abnormal is if you don't know what a normal tendon looks like.
I like the thinking of that. I like how you just said it's the process of you start here at an exact certain point, and then from there you go to the next structure, and then from there you turn right. It's got this pattern to it. But I think some people can learn things like that quite easily, and other people would find it hard to stick to a structure.
Yeah, and it doesn't matter on the order. So the sonographer that I teach with, she scans it the opposite way around, but it's still systematic. She just
Yeah.
goes this structure and I go the opposite way around. It doesn't matter which way you approach it. It's just you have to be systematic in that approach. It's like every other clinical skill. It's if think about the first time you did like a nail surgery. Remember the stress when all the ordering is out because you haven't done it before. So
Yeah.
you put gloves on and you go, oh, I've got this is still, I haven't opened my dressing to put in there. So it just feels like a bit of a mess in terms of the process. But
Yeah.
then after you do 10 or so of them, you can almost like not switch off, but there's a serenity that comes with the order and the process. And you do the same process each time, and it actually drops that sort of cognitive load. So it makes the whole thing easier for you to deal with because it's ordered.
Yeah. But I used to do the same thing even when I did my biomechanical assessment. I had a
Exactly.
set structure on
Yep.
where I started, what was the first thing I looked at, and I had this process that I ran through. It might have been whether it was 5 or 10 things at the time, depending on the problem. And that's how I taught everybody: start here and go through that process. But like you said, they don't have to start here. As long as they get through all the steps,
Yeah.
they just need to start somewhere and finish somewhere so that everything is actually ticked off. You're not missing things with different people, different patients.
And again, you've also got to have, and this would be, I remember looking at the biomechanical forms when you're in student clinic, and there
Yeah.
was like it's basically like 8 pages long. Okay.
Yeah.
And then the last part was the really important part. And it was basically like, how do you integrate? Like, what does all this mean? And that was always the part that was never filled out. So all the bits of like measuring joint angles and stuff like that was always filled out. And then the bit was like, how do you integrate? What was the point of the biomechanical assessment? Like, what are you trying to achieve with it? How's this going to influence your decision making? That's the important point. So the same thing goes whether you're doing an ultrasound scan or a biomechanical assessment. You're not just doing the assessment for the sake of doing the assessment. There's something that I want to get out of that. There's some sort of,
Mm.
I want to make a decision based off that knowledge.
As you're going through your structures, though, or you're going through your process, are you eliminating things as you're going through as
Yeah.
well?
Yeah.
So you've got 4 or 5 things going on in your head, and as you go through that process, you go eliminate, move on to the next thing,
Yeah, that's
eliminate.
interesting. That's interesting. Yeah,
Yeah.
this sort of increasing. And then once I finish that whole thing, then I'm like, okay, I now know I know what's damaged, I know what's not damaged. So I've got you started to build a clinical picture of what's going on here. Because some patients are really good historians and some patients are really terrible historians and they're all over the place. They're telling you a lot of stuff that's irrelevant. So sometimes it's helpful to be able to pull that probe out and actually have a look at those particular structures that you might be interested in. And sometimes, for example, like I see quite a lot of teenagers with, say, sesamoid stress fractures. And you can certainly, ultrasound's really sensitive for picking up like a cortical break or cortical irregularity. But I'm not always necessarily, so if I see, this happens many times, like I look at someone who presents,
Yeah.
say medial, focally tender, that medial sesamoid, the history lines up as well. They've got this sort of persistent pain for a few months. It's not getting better. It's worse with activity. It might have a little bit of nocturnal pain. Sometimes they don't. You palpate focally tender on that sort of, medial lateral sesamoid. You put the ultrasound on and there's like a cortical irregularity. There's a break in the bone cortex. Now, the way I typically, if that's like an acute injury or acute sort of stress fracture in a teenage athlete or young athlete, I tend to prefer just below knee non-weight bearing cast for those. But I'm not going to make that call off the ultrasound. So I'm going to say the ultrasound's abnormal, but I'm not making the diagnosis at this stage, even though I'm looking at it with the clinical history and stuff, and I'm 95% sure there's a stress fracture. I'll tend to then refer them for an MRI. Then when it comes back as a stress fracture, we've got confirmation. Then it's easier to make that clinical decision to say, okay, it needs to go into a cast for a period of time or it needs to be offloaded because there's that higher risk of this not healing properly and this being a much more long-standing chronic issue. Yeah.
Okay. Before we wrap up, where are you doing your courses? When's the next one? If people want to find out about them, I know you're talking at the Lower Limb Conference
Yep.
in
Yes, I'm
November.
looking forward to that. I'll be at the Lower Limb Conference in November. I think that's the 8th and 9th of
8th
November.
and 9th of November. Yeah.
Yep, this year up in Brisbane at the Vald Centre. So that was an amazing conference last year. Really, yeah, a lot of fun. It was really interactive. It's a great venue to do it because we had workshops running at the same time that lectures were, and people could just move between. So not an old school formal academic style conference.
All the reports I got back from it, it was fun.
It was fun. It was fun. It was fun presenting there last time and doing workshops and talking to everybody and the social events and the networking. So hope to see you in November. And the next one, I'm actually in Brazil. I'm talking to a conference on point of care ultrasound in Sao Paulo on the 8th of June this year. That's the next one. So
trip.
If anyone wants to make their way out to South America, that'll be, as I said, my Portuguese is not very good. Zero Portuguese, but I think it's going to be a bit of a mix. So I do quite a bit of teaching in South America. So I've got friends that are over there that run an ultrasound training institute. They're both my friend Worley. He is a cardiologist, intensive care doctor, and runs an emergency department over there. So last year we did some teaching in Santiago at the Metropolitan Hospital, and the year before we were in the Amazon. We taught some doctors in the Amazon point of care ultrasound. So this year we've got a global conference on point of care ultrasound in Sao Paulo at his hospital.
Is there a website where people can find out about that?
Maybe have a look at my Instagram, which I don't even know the handle for. I'm so bad with social media.
Oh, that's right. You send me the information and I'll put it in the show notes, and that will force people to go to the podiatrylegends.com website.
Yep.
Look at the show notes, you lazy buggers, and you can get the information there. So we won't tell them now. Bugger them.
Yep. We've got an ultrasound. I think the next ultrasound course is coming up in July. That's at Zedu Ultrasound Training in Melbourne. So if you Google Zedu and reach out to them, you'll see the course dates on there and all the details, and you can contact Samuel and he can manage all of the inquiries and things with regards to ultrasound. We also have another one coming up towards the end of the year in November as well. And later in the year, there's an injection. So I just did an injection workshop in Adelaide with Craig Wanless, a podiatrist, and Dr. Ramona, who's a MSK doctor up in Adelaide. So we're doing another one up in Noosa in second week of September. I think it's the 12th, 13th of September. It's a Saturday, Sunday up there.
Okay, well, same thing.
That's the next one.
Send me all the links. I'll put them in the show notes. And people can go and check that out. So is there anything else you want to say before we wrap up? Because I've really enjoyed this. I think if somebody has been thinking about using ultrasound in the clinic for like point of patient care, I think this will really get the juices flowing.
Look, the only thing I'd say is one of the questions I get asked all the time is, I've got a lot of LinkedIn and emails about people that haven't used ultrasound before. They ask whether they should buy an ultrasound before they come to the course or vice versa.
Yeah.
My advice is always to just come to the course first, because the course is set up with you not needing to have a lot of ultrasound skills. It's often good to just come in fresh. We don't have any brand alliances with any of the ultrasound manufacturers. We have ultrasounds from all manufacturers. So we've got GE, Clarius, Mindray, Sonosite, all the different brands, all the way down from your handhelds, a few $1,000s through to $150,000 sonography systems. So the advice is that you need to come in and you need to use those devices, because at the start, you don't know what you don't know, and you don't know what image you need, and you don't know what you're going to use that ultrasound for. So that makes it's often helpful to come in and actually scan and start to think about how this ultrasound is going to fit into your practice. Is it something where you just want to measure the plantar fascia thickness in the Achilles tendon? Your handhelds are going to be completely fine at doing that. But are you going to want to do a lot of interventional stuff? So do you want to do a lot of nerve blocks and injections on a daily basis? Then you're best to skip the handheld phase and buy a more expensive cart-based machine. You're going to pay a price difference, but in the long run, you're going to outgrow the handheld very quickly. So the handhelds are great. It depends what you want to use it for, and it depends on your budget as well.
That is fantastic advice. So James, I want to thank you for coming on the Podiatry Legends podcast. Like I said, it's my fault that it's taken 4 or so years to get you on here. I apologize to everybody listening to this. You should have got this information earlier. So James, thank you very much.
Thanks, Tyson. Appreciate you having me on.